Dear all, my name is Evandro De Azambuja, medical oncologist from the Jules Bordet Institute in Brussels, in Belgium, and it's my pleasure to be here to report the OncoAlert Colloquium 2026. And it's my pleasure to talk to you about HER2-positive early breast cancer. These are my disclosures. If I can summarize 2025 in few trials that have been presented, we have some confirmatory evidence like the APHINITY trial that showed that a median follow-up of 11.3 months, the combination of Trastuzumab Pertuzumab showed an improvement in overall survival in the node-positive early HER2-positive breast cancer. The KATHERINE trial confirmed that TDM1 also improves overall survival compared to standard of care, meaning keeping Trastuzumab in patients with residual disease. The ALTTO trial, a sub-analysis showed that almost 10 years, we looking into either aromatase inhibitors or Tamoxifen in patients with hormone receptor-positive HER2-positive early breast cancer. You can see the AI aromatase inhibitors are better than Tamoxifen. And the new emergent strategy, the DB Destiny Breast 05 showed that Trastuzumab deruxtecan is better than TDM1 in the post-neoadjuvant setting patients with residual disease. A DB11 showing that the Trastuzumab deruxtecan, the ADXD, is better than chemotherapy when used in the neoadjuvant setting. And lastly, the new Carpenter Ellen trial, two trials to de-escalate therapy in patients with HER2-positive early breast cancer, showing that carboplatin is no longer needed in some patients. Let's start with the APHINITY trial. So just to remind, the APHINITY was a phase 3 trial with 4,805 centrally confirmed HER2-positive early breast cancer setting. Patients had surgery and then they were randomized to receive chemotherapy plus Trastuzumab plus Pertuzumab or chemotherapy plus Pertuzumab placebo. Follow-up was up to 10 years. In this trial, 38% were node negative, 37% 1 to 3 node positive, and 4 or more positive lymph nodes, 25%. So it shows that over 60% had node positive disease. The trial showed that a median follow-up of 11.3 years, there is an improvement in overall survival at the magnitude of 1.8%, when you can see that this is driven by the node positive population. So the overall survival improvement is in node positive disease. We also show a descriptive invasive disease-free survival analysis showing that the addition of Pertuzumab to Trastuzumab chemotherapy improves the IDFS. The magnitude is 3.4%, and this is mainly for the node positive disease. We don't see any improvement in the node negative. So today, the standard of care for patients in node positive disease is to use Pertuzumab and Trastuzumab with chemotherapy. Let's move into the KATHERINE trial. The KATHERINE trial for patients who received neoadjuvant chemotherapy with Trastuzumab, and 18% had dual blockade of Pertuzumab Trastuzumab. Those patients had surgery, and if they had residual disease, they were randomized to receive TDM1 for 14 cycles or continue on Trastuzumab for 14 cycles. Radiation and endocrine therapy were according to local guidelines. The trial showed the final results with 8.4 years median follow-up, and you can see here the invasive disease-free survival is better if you switch to TDM1 in case of residual disease compared to keep on Trastuzumab, at 13.7% advantage for TDM1. We also see that in terms of CNS recurrence, there is no difference. We see numerical lower in the Trastuzumab group, so what we see here is that there is a marked prolonged IDFS benefit with TDM1, but there is still a poor penetrance in the central nervous system with TDM1. And they were also looking into overall survival, that was the final results. So if you switch to TDM1 in patients with residual disease, there is a benefit of 4.7% for TDM1 compared to keep on Trastuzumab. And this really confirms the value of surrogate endpoint in patients with early breast cancer. But what you can see that the TDM1 is better than trastuzumab in those patients with residual disease in all subgroups, but it's still some of those subgroups is still, if they have a high tumor burden, they still do very poor at 7 years. So that's why it's important to have new strategies, and I'm going to discuss this, the trastuzumab deruxtecan later. Let's look into the Ellen and to the NeoCARP trials, two new strategies. The NeoCARP 774 patients were randomized to receive a neoadjuvant taxane with pertuzumab, trastuzumab for 4 cycles, or taxane with carboplatin, pertuzumab, trastuzumab for 4 cycles. In this trial, 50% were premenopausal, T1, T2 tumor 81%, stage 2 77%, hormone receptor positive 62%. And the LN006, previous untreated stage 2 and 3 HER2-positive early breast cancer, also almost 700 patients were randomized to receive nab-paclitaxel with pertuzumab, trastuzumab, or docetaxel carboplatin with pertuzumab, trastuzumab. And here the question is, do you really need the carboplatin for those patients? If you see in the NeoCARP, the pathological complete response was similar between the two treatment arms, around 65%. So carboplatin did not add anything in this case. And this was equally similar in hormone receptor positive and hormone receptor negative. And the Ellen again showed that the nab-paclitaxel with pertuzumab, trastuzumab has a higher pathological complete response rate compared to taxane, carboplatin, and pertuzumab, trastuzumab. So we see that there is no need for carboplatin in those patients, but we still wait results of the survival outcomes. But it's still a strategy to decrease carboplatin in some patients. Let's look at two other trials, the DB06, the Destiny Breast 05, and the Fascinate-N. Start with the Destiny Breast 05. Those are patients similar to the KATHERINE trial, patients with residual disease, but here they were a high risk, defined as inoperable at the diagnosis or operable with a node positive after neoadjuvant chemotherapy and anti-HER2 drugs. So patients were randomized to receive a comparison head-to-head trastuzumab deruxtecan or TDM1. As you can see in this patient population, hormone receptor positive 71%, inoperable half of them, 50%, trastuzumab alone only 21%. Here, almost 80% receive trastuzumab pertuzumab in a neoadjuvant set, which represents our current practice. Anthracycline, half of those patients, 50%. What you can see that trastuzumab deruxtecan has a better invasive disease-free survival, 92% compared to 83% with TDM1. So an absolute benefit of 8.7% improvement for TDXD. And if you look on the right-hand side of this curve, this IDFS, there is a marked benefit, specifically in those with node positive disease after neoadjuvant treatment, those with inoperable disease at the baseline, and those with anti-HER2 blockade. And if you look in disease-free survival, distant disease-free survival, you can see there is still an improvement, 7.8%, less distant relapses. And if you look into central nervous system, there is numerically lower central nervous system metastasis with TDXD compared to TDM1, but it is still very premature and needs to be followed up. In terms of safety, you see that there is a similar number of grade 3 adverse events, more serious adverse events with TDXD, more discontinuation, and similar dose reductions. Death were similar in both trials, and you see more interstitial lung disease, 9.6% with TDXD, 1.6% with TDM1. And the Fascinate trial, again, is testing a new ADC, trastuzumab deruxtecan. And here, what the authors did, 265 patients, 87 per arm, a small number. They were randomized to receive this new molecule alone, this new molecule plus pirotinib, that is a TKI, or the carboplatin, nab-paclitaxel, trastuzumab pertuzumab, this standard chemotherapy. As you can see, overall, according to hormone receptors status, there is no difference. So if you look, single agent derives uh, the same PCR as polychemotherapy. And the addition of pirotinib to the trastuzumab rezetecan did not increase in efficacy, but increase in toxicity. So there is very interesting, should be explored further whether one single agent can replace polychemotherapy. And finally, we have the Destiny Breast 11. It's a neoadjuvant trial with 3 arms, phase 3, 3 arms, with trastuzumab deruxtecan followed by taxane pertuzumab trastuzumab, or anthracycline cyclophosphamide followed by taxane pertuzumab trastuzumab, or trastuzumab deruxtecan alone. Please note that the arm with trastuzumab deruxtecan alone was closed prematurely, and because it was inferior, so this was not presented in terms of event-free survival, but only is slightly discussed about the PCR that is inferior. So patients receive a total of 8 cycles, and then they go to surgery. So here you can see that the majority, high-risk disease, the majority were node-positive disease with almost 90%. Half of them, they were T3 or T4 disease, and you also include inflammatory breast cancer. As you can see, the pathological complete response in the ITT, there was a 11.2% benefit for TDXD followed by THP compared to anthracycline and THP. If you see the hormone receptor positive 9.1% and the hormone receptor negative 16.1%, showing that this strategy is interesting and only 4 cycles of TDXD. And if you look in terms of RCB, residual cancer burden, you can see that similar results were found. We looked into event-free survival. At this moment, it is still immature, but you see a separation of the curve with a numerically higher event-free survival in the TDXD THP arm, 96% compared to 93%. This is still immature. We see that the node-negative population for the moment do not derive any benefit. This should be explored further, but the vast majority of patients were node-positive disease. In terms of safety, you see less grade 3 or serious adverse events with TDXD, THP, less treatment interruptions, less left ventricular dysfunction, but you see more dose reductions, more discontinuation, and more surgical delays. In terms of ILD pneumonitis is similar, number of deaths similar, and any grade adverse events similar. So still looking further what we had in 2025, the ALTTO trial reported this important sub-analysis with 2,651 patients with hormone receptor positive, HER2-positive early breast cancer that have been enrolled in 3 arms of the ALTTO, trastuzumab followed lapatinib, or trastuzumab plus lapatinib. The lapatinib alone arm was not included. And here the comparison was aromatase inhibitor alone versus SERD alone. And we want to see whether there is a difference in terms of invasive disease-free survival, time to distant relapse, or overall survival. As presented in San Antonio, 2025, if you look in terms of this disease-free survival, there is an improvement for AI compared to SERD alone, 8% versus 76%. Also, in terms of overall survival, here you don't see any difference. They are very similar. But if you look in terms of postmenopause and premenopause, the postmenopause, we had 73% with SERD alone compared to 79% with aromatase inhibitor alone, showing that there is a better outcome for patients postmenopause treated with AI. Similar in the premenopause, you see this magnitude much better, 77 versus 90%. So showing again the aromatase inhibitor plus ovarian function suppression or SERMs plus minus ovarian function suppression, the better outcome is with AI aromatase inhibitors. And the last trial is this meta-analysis that compile different trials look for HER2-DX, that's a kind of oncotype for HER2-positive disease that combines nodal stage, tumor stage proliferation, tumor type, HER2 amplicon, and immune IgG signatures. As you can see here, with 2,518 patients, you can clearly see that the HER2-DX can really discriminate those patients who have a low risk of disease, the red curve, 93.6 percent of event-free survival at 6 years, compared to 82.9%. Statistically significant and very important. So this is being prospectively tested in clinical trials and might provide more granularity to decide which patient should de-escalate or escalate treatments in HER2 early breast cancer. So this was what I had to present for you today. It was my pleasure to be here, and I hope you enjoy the Oncolert Colloquium 2026. Thank you very much.